Good day, and welcome to Epstein, Becker, Green, and EBG Advisors webinar, The Challenges and Rewards of Integrating Behavioral Health into Primary Care, part of the Thought Leaders and Population Health webinar series. Before we begin today's presentation, please be informed that today's webinar is being recorded and the participant phone lines will be placed on mute throughout the program. You are welcome to submit questions throughout the program by using the Q&A feature provided by WebEx, and at the end of the program, with time permitting, the speakers will address your questions. You are also welcome to submit questions directly to the presenters following the webinar, and contact information will be displayed at the end of the presentation. And approximately 2 to 3 business days following the webinar, Epstein, Becker, Green will communicate the availability of the webinar recording and access to the PowerPoint materials. We hope you will join us for upcoming webinars. For additional details or to watch recordings of previous sessions, please visit www.ebgadvisors.com. We are pleased to have 3 fantastic speakers today. Epstein, Becker, Green's Mark E. Lutz, member of the firm and chair of Epstein, Becker, Green's Board of Directors. Charles A. Coleman, senior sponsor of IBM's Population Health Insights and Programs Management of IBM's Healthcare Solutions Board. And Stephen R. Davis, Chief Medical Officer at M3 Information, LLC. At this time, I'd like to turn the webinar over to Mark E. Lutz.
Thank you, Whitney, and welcome everyone to today's session. We're thrilled to have another opportunity to speak to you about the evolution of implementation tactics around population health and to continue the tradition of bringing to you thought leaders in the space. Today's topic reminds us of the staggering cost and quality implications of potentially failing to integrate behavioral health conditions, mental health conditions as a companion diagnostic or comorbidity in plans of care. We have, relative to that challenge, I think a call to arms today. But beyond that call to arms, which we will be reminded of, we have an opportunity to think creatively together with 2 prominent advisors in this area. Initially, we're going to hear from Dr. Stephen Davis. As Whitney indicated, he is Chief Medical Information Officer for M3. He's a physician double-boarded in psychiatry and psychosomatic medicine. He's a clinical assistant professor at University of Maryland School of Medicine. Has been a past chair of the Department of Psychiatry at a prominent medical center. Works with the American Psychiatric Association on mental health information technology, as well as some credentialing organizations. So he is well equipped to take us on the first step of the journey of answering that call. Specifically, we're going to ask Dr. Davis to help us understand the evolving concept of collaborative care relative to mental behavioral health and what tools exist today around the implementation of that, and particularly tools that might be available and what we might expect from metrics for measuring success in patient engagement, patient management in the context of collaborative care. Then we're going to turn to Dr. Coleman, IBM's Dr. Coleman, also well-credentialed, particularly around PTSD, depression, anxiety diagnoses, and ask him to bring us up to date around the opportunities that IBM sees in the integration of clinical data with mental health data, particular tools to accomplish that, and then to give us some guidance as to how this integrated data can be leveraged at 3 very important junctures, which many of you are probably struggling with. One of those junctures being at the risk stratification juncture of treatment development, patient identification around risk stratification, then the implementation of care planning, and finally in the ongoing challenge of patient engagement. So I apologize to the speakers for asking so much of them in such a short time, but we're looking forward to hearing what they have to say around these issues. Dr. Davis, do you want to kick it off?
Oh, sure. Thanks, Mark. I appreciate that. So good morning and good afternoon to our participants. So I'm going to start with so the first slide is up about integration, and I just wanted to put a little bit of perspective and where I'm going to mention a number of issues around behavioral health and how it relates to general health care, integrating behavioral health care, and then I'll be drilling down on some of these topics. So I want to talk about first the silos that we have around behavioral health and physical health. We have certainly in the United States and much of the world, there's been this kind of division between the mind and the body. And, you know, going back to René Descartes and before, where people are talking about how there's a difference between the mind and the body. And, of course, the mind, people talk about how much of it is in the brain. And, unfortunately, our healthcare system has evolved to keep these things rather separate. Now, over the past number of years, we've been slowly integrating these things, but these silos continue to exist in many different ways. That has contributed to concerns about stigma that people have about, quote unquote, being crazy and getting psychiatric care or something wrong with their brain, and discrimination that happens. And in fact, some of that discrimination has been in the insurance industry as well. As a result, back in 1996, the Mental Health Parity Act was signed into law by President Clinton. And that only got kind of so far, and as a result, a subsequent Mental Health Parity Act, the Mental Health Parity and Addiction Equity Act in 2008 was signed into law by President Bush, and it actually took about 5 years for the regulations to come out. And so we're still working on this, this idea of parity, of treating mental health and substance abuse problems in the same way that we manage physical health problems and not put extra limits on care. Now, just a word about language. So I'm going to be talking about behavioral health, and that's a term that gets used in different ways, but in the term I'm using it is a combination of both mental health and substance abuse or addiction treatment. So I'll kind of use these terms rather interchangeably. On the legal side of things, aside from the Parity Acts, of course, HIPAA was passed a number of years ago, and there were distinctions made in HIPAA about psychotherapy notes. And I'll just kind of mention this. I won't talk about it further. But those are specially defined notes around psychotherapy and around private mental health information that's unrelated to diagnosis or medications or mental status symptoms. Unfortunately, most electronic health records have yet to adequately incorporate the protections that were inserted in HIPAA around psychotherapy notes. So as a result, most mental health information is still just in the general medical EHR. In fact, health information exchanges typically will exclude mental health and substance abuse conditions, in part because of concerns about these restrictions, but also there's a lot of state-level laws that make for state-to-state differences. And then on top of that, there's a federal law, 42 CFR Part 2, which addresses to what degree you can share information from formal substance abuse programs. This really relates to addiction treatment. And it does not relate to addiction treatment provided by, say, a primary care provider. This is just about methadone clinics and other formal substance abuse programs. Important information to have in managing a patient, but there are a lot of limitations, and I think that's something that's starting to be addressed now legally about how can we improve access to this information, but at the same time these were put into place because people were afraid that if everyone knows my business, then I might lose my job, my insurance might cost more, et cetera. And so that's why these were put in place, for fear that people just would not seek treatment. And I think that's a big part of the concern about privacy that we have around behavioral health. And people are starting to be more open about it. It used to be that you couldn't talk about cancer without whispering it, and now people talk about it and it's open. And I think eventually we'll get there with behavioral health. Clinical issues, this issue about where to treat, primary care versus specialty care. One point I'll make is that not every patient with diabetes is managed by an endocrinologist. In fact, most of them are not. Primary care feels very comfortable managing diabetes, and when they get into trouble, or they need some help, then they'll seek out specialty care. Same thing really should be for behavioral health. There are coding issues that sometimes interfere and cause barriers because of the split, these silos of maybe a managed care organization versus a specialty behavioral health organization that manages and pays for behavioral health conditions. Oftentimes a primary care doc is not a member of that company payer. However, if they put in a claim with a certain diagnosis, sometimes it gets kicked back. So these are problems that interfere. But really focusing on the whole person is where we're moving towards, especially as we move towards more value-based purchasing methods of paying for treatment. And then finally, I'll mention something about multidimensional mental health. Much of primary care has focused primarily on depression, and I think that's possibly because we have a tool, PHQ-9, which is prevalently used to measure symptoms of depression. Yet, what happens is that there's a lot of other conditions that are missed because of that. So you really have to take a broader view. And then, under technical, I'll mention a couple of these things because I won't be talking about them again. DS4P, or data segmentation for privacy. You should write that down and look that up. And in fact, in the slides that come out in a few days, I've put some links in the slides so you can find the information quickly. But that's a way to tag data in such a way that the consent that patients have with respect to their sensitive health information, like mental health, like substance abuse, can follow along with the information. And implementing this type of open source technology into EHRs and HIEs, which is starting to happen now, will increase the availability of this type of information, yet maintain the patient's trust that they know where the information is going and they can control it. The C2S is consent to share, which is part of this sort of technology. Another issue I'll point out about is who owns the data. And so this is a frequent thing that's talked about in healthcare. Does the patient own it? Does the doctor own it? Does the payer own it? And so forth. And patients are increasingly expecting that they can control access to their information. And the more that they feel like they can control it, the more trust they'll have in it. The more trust that they have in it, the more likely they'll be open to sharing their information with everyone involved in their care. Let me move on to the next slide. All right, so this affects a lot of people. In the U.S., over 40 million adults have an anxiety disorder, for example, in any given year. 35% of people with chronic medical illnesses also have a mental health condition. The flip side of that is about 70% of people with mental health problems also have chronic comorbid medical conditions. A good quarter or so of people on a year-to-year basis, according to NIMH, have a diagnosable mental disorder. Many of those are mild to moderate conditions. Maybe 5 or 6% of the population might have more severe conditions. As far as costs go, the unmanaged patients and well, I'd say unmanaged patients tend to cost more than double for any given chronic medical condition that they may have a comorbidity with. So I'll show you data in a few minutes. highlighting that. The World Health Organization estimates that about the value, in other words, the cost of mental illnesses, including substance abuse, across the world is about $3 trillion. Much of that is in lost productivity and disability costs. Costing businesses a lot of money, of course. $3 trillion is a lot. As far as readmissions go, something like a little bit more than a quarter or so of readmissions are impacted by mental illnesses. It's probably more than that. The Project RED found, which is about reducing readmissions, found that about 25% of the readmissions had depression, which played a role in the patient's ability to follow through with recommendations and therefore the readmission. Next slide. Just some busy slide here, but just a quick snapshot that diagnoses often go mental health conditions often go undiagnosed 70 to 85% of the time. And of course, if you can't measure it, you can't even identify it, it's hard to manage. And as you can see across these 10 or so different medical conditions, this is a slide from a commercial payer showing their costs on a per member per month basis for people with a behavioral health condition. So I'll pick asthma as an example, costing about over $800 per month if they also have a behavioral health condition, but $470 without on average. And then you see some numbers about how many are being treated for depression or anxiety and what the expected prevalence is just from population data, demonstrating there's a lot that are being missed. Next slide, please. So life expectancy for people with behavioral health conditions on average is lower than those without. And we're talking 10 to 12 year less on average across all behavioral health conditions. And for people with more severe mental illnesses, those that are treated by Medicaid or public sector funds, some studies show that that's 15 to 25 years life expectancy cut short. A lot of that has to do with smoking. Smoking is probably about half of it. There's a lot of people smoking with mental health conditions. But a lot of that is also driven by problems with access to care, especially access to primary care, poor integration of primary and behavioral health care. And, of course, there's a lot of social determinants of health that are baked in, I think, to this reduction in life expectancy. Next slide, please. All right, so I went through these figures a minute ago. That it's very clear that there's a connection between physical and mental health, that they're really part of the same whole person. And by paying attention to this, we can reduce suffering, improve quality of care, and significantly reduce health care costs. Next slide. So a few years ago, I'm in Maryland, and I was on a Medicaid task force about integrating behavioral health in primary care settings. And what we did was we took data from the managed care organizations, which had all the medical claims data, and the managed behavioral health organization, which had the mental health and substance abuse stuff. And they weren't really, no one had put these things together before. So the left hand and the right hand don't really know everything that's going on in the other person's camp. What we found is that and this is we did this for about 10 DRGs. For diabetes, you can see here that this is the relative risk of a hospitalization in 2011 for adults. And this is not mental health hospitalization. This is hospitalization for principal diagnosis of diabetes. For those who had comorbid mental health conditions, it was 3 times higher. For substance use conditions, it was 4 times higher. And if they had both mental health and substance abuse, 13 times the increase in relative risk. So they were hospitalized 13 times more often than somebody without these comorbidities. Next slide. Same for these 4 respiratory conditions, COPD, asthma, pneumonia, bronchitis. You see even higher figures, for the combination of mental health and substance abuse, 15-fold increase in hospitalization rate for these patients. And you can imagine why this might be, because people who are too depressed to care for themselves or to follow a plan for their COPD or for their diabetes are more likely to have impairments, or more likely to suffer complications from these conditions. Throw in substance abuse and it's a lot worse. Next slide. This is the last of these, showing you cellulitis and septicemia. Just for these two DRGs, very significantly higher, particularly on the substance abuse side. And if you think about it, now this is Maryland, a lot of this data is coming from Baltimore. We have a high amount of heroin use in our area, and if you're injecting medicines, you're going to have more problems with infections, costing a lot of money. Next slide. As far as readmissions go, so this is data showing that depression, if you have comorbid depression, increases the risk of a 30-day readmission by as much as 40%. And there's other studies that find this as well for some of the same reasons. So it's costing the system a lot of money, and people are being unnecessarily rehospitalized. And to the extent that we as clinicians and as healthcare systems are paying the price for readmissions, and by paying attention to and integrating behavioral health, you can have an impact on that. Unfortunately, there are still people who feel like that's not part of primary care. It needs to be off in something separate. And I think they maintain that feeling, I think, at their own peril, because if they don't do anything about it, they're not going to be able to have as much of an impact on these costs. Next slide. Another slide of data from commercial payers showing the increased cost of chronic medical conditions when there's mental health comorbidity across these 5 conditions: cancer, CHF, diabetes, COPD, and asthma. A good rule of thumb is it's going to cost about double on average, and that's, if I had to summarize the data out there, 2 to 3-fold seems to be pretty consistent. Next slide. Some additional data with some other conditions, different set of data, though, showing the same types of thing. In fact, some of these costs are as much as 4 times as much. Next slide. And this slide from the last year's report from Milliman that also shows both the Medicare and Medicaid costs, the impact on these costs of having a behavioral health condition and the comorbidity with mental health or chronic medical problems. Next page. And one last slide along this this idea of increased cost. This is a set of estimates across from 2 different models showing, and this is just for 6 medical DRGs, the top 6, showing anywhere between 220 and 235 billion dollars of potential savings. Now, not all of that money, I think, can be captured, but it seems very clear that a good chunk of it can, especially if people are treated better. The interesting thing about this slide is that something like 75 to 80% of these excess costs are on the medical side, not on the behavioral health side. Again, because of increased complications and so forth. Next slide. Unfortunately, this is from Health Affairs 2013's national survey of ACOs, finding that very few of them are integrating behavioral health, mental health, and substance abuse in their settings. And I think they're starting to wake up and pay attention to this, but change is slow. Next slide. This is data from a randomized trial showing that when you compare usual care with a type of integrated care called collaborative care, that there's a 40% reduction in this study of cardiovascular events in the group that had collaborative care for depression versus usual care. Next slide. The impact of this, and you see the word impact, which refers to a specific program out at University of Washington, found that using this collaborative care model, for every dollar invested in the model, there was a return on investment of over $6. Pretty significant. Next slide. This slide shows you in general the collaborative care model and what it looks like, but essentially it involves both the primary care practitioner, the patient, and having someone who serves as a behavioral health care manager within the practice. This is oftentimes a nurse, sometimes it's a social worker or a psychologist. There may be other behavioral health clinicians involved. And there's a consulting psychiatrist who typically will be, this is often mostly done remotely on the phone or maybe through the web, and they serve as a consultant to the primary care practice. Pretty much like what you're familiar with curbside consults, where they're reviewing a registry of patients, looking at what their symptoms are and medications and so forth, and making recommendations. And this is the collaborative care model, which is shown to be over 80 studies very effective. Next slide. Real quickly, I'm going to wrap up in the next 2 minutes or so. So this is just a reminder that anxiety disorders are twice as common as depression, yet depression is probably the thing that's most measured when something's measured at all in primary care. Another point is that 20% of people who score positive using a PHQ-9 or other standardized depression tool, 20% of those actually have bipolar disorder. And if you treat somebody with bipolar disorder, say with an antidepressant, you're much more likely to have a worse outcome than if you provide bipolar aware treatment. So you need to measure, think of these things and measure them. Next slide. By only looking at depression, so here you see on the left PHQ-9, which measures depression, GAD-7 measures anxiety, MDQ for bipolar disorder. If you're only doing one of these things, you're going to miss some of the other conditions. So you really need to either do multiple screens or assessments if you're monitoring somebody, or use something that addresses all of these things. The M3, and it's a company that I work for, we have a multi-dimensional mental health tool that addresses both depression, bipolar, anxiety, PTSD, and there's some substance abuse questions as well. And by doing that, you get a much more whole person view. Next slide. I'm short on time, so I'm not going to go through the details of this, but you'll be able to find it in the slides. But essentially, similar or better sensitivity and specificity compared to single disease measures in primary care populations. It only takes about 3 minutes or so for the patient to complete. Next page. This is an example of the report that's output by using the M3 clinician. And you can see kind of a total score, which is nice because our total M3 score aligns well with the SF-12, which is a measure of essentially of quality of life. And you see subcomponent scores for depression, anxiety, PTSD, and bipolar disorder, which are very useful in managing these cases, especially in a collaborative care setting, because now both primary care and specialty care can speak the same language. When you say the person has an M3 score of 48, you kind of know what that means. Next slide. All right, so I've reviewed. This is where I'm going to switch over to Charles in a second. But the points I've made here are really that mental health and substance abuse integration is as important to primary care as integration for diabetes treatment is. That integration goes beyond just depression and should encompass commonly encountered behavioral health problems in primary care settings, including anxiety disorders and substance use. There are tools you can use to improve your confidence and competence in managing these patients, and that the avoidable costs if integration is ignored, is in the hundreds of billions of dollars per year for the United States. So I'm going to turn the rest of this over to Charles Coleman. Charles?
Steve,
thank you, Steve.
Do that. Let me just drill down on one thing, Mark. So I hear the argument for tools that give the clinician a broader view. How often in the collaborative care model are the tools being utilized and repeated? I imagine that beyond the initial diagnosis, there's also a tracking and a tracking function that needs to be paid attention to by the care plans of the folks on the phone. And
sure.
Can you speak to that before we?
Yeah, I can, Mark. Thanks. So the collaborative care model really requires measurement of the patient's symptoms. You need some tool to measure, or tools, depending on what their problems are, to measure their symptoms, to know, are they getting better or not? Because oftentimes, without such a thing, all you're left with is asking some questions, and the patient is often, better, not better. Sometimes just do on a scale of 1 to 10, how are you feeling today, something like that. This gives you much more detailed data upon which to act and to help make clinical decisions. And so this requires having, setting up a registry. And a lot of practices using a collaborative care model, because EHRs don't generally have this set up really well to do this sort of population level of management, which is really what we're talking about, is looking at entire populations. We need better technological tools to do this. And oftentimes you're talking about an Excel spreadsheet where the behavioral care manager manages the list of patients that are being treated for these problems and are being overviewed by the psychiatrist, a list of what their medicines are, what their the pattern of their symptoms based on these measurements over a period of time, so you can see getting better, getting worse, what made things better, what made things worse. And usually you're connecting this to some of their more significant chronic medical conditions, because you want to see that you're having an impact on their blood pressure, on their hemoglobin A1C, on cholesterol, and other measures that are important. CHF patients going to the emergency room, things like that. So yes, Mark, you definitely need to always, I think in collaborative care, you're always going to find use of measurement tools, and these tools help efficiently communicate information amongst the specialty care providers and the primary care providers.
Thank you. Charles?
Yes, thank you, Steve and Mark. Steve, that was an excellent overview of the sources and scope of the obstacles. We're going to want to back up the slide. For integrating mental health with physical health with the PCPs, as well as, I think, identifying much of the progress made on the legal, social, financial, and practice fronts. And whereas Steve has defined the what of the problem and the why we need to integrate behavioral with physical, I'm going to cover the how today's technology is enabling comprehensive integrated care at the point of care. And one of Steve's main points was that we actually begin this journey with data. And that's why I've emphasized that being able to get access to data through conventional means, and also some of the new ones where consent is now being a more open volume of information that the patient can control. And one of the handbooks that we use with our populations is the provider-led population health management primer that was written by Richard Hudash some years back, but it's an excellent book. You can see it down the right-hand corner there. Very, very good. So I would suggest that you might take a look at that to see how population health management is really being played out through the eyes of the providers. I want to just mention a couple things on this slide. One of them is that it appears that the integration of behavioral health is following a track similar to the meaningful use tracks that we're all used to hearing about. I'm going to talk a little bit about that, and I'm also going to talk more specifically around those 5 bullet points at the bottom, the sophisticated analytics, the patient risk similarities, new patient engagement tools and mobile apps, integrated care plans, which Steve discussed, clinical, behavioral, social, mental health, evidence-based proactive interventions, because we're trying to get from reactive medicine to proactive medicine on all fronts. And that requires some predictive models that we now have in place that we can actually use and leverage. And of course, as we've mentioned already, the care coordination to improve outcomes and lower costs. So advance, please. Next slide, please. Thank you. So there are a lot of industry drivers that we're all familiar with because we've been watching these trends for so long. You know, HIM-7 is certainly one of the landmark ones. There's others, the triple aim, the HRQ, and advance, please. Next slide, please. I'm going to talk specifically about meaningful use in this discussion. And one of the things that we've noticed in meaningful use is this sort of journey map, if you will, from data capture and sharing to advanced clinical processes to improved outcomes. And it would appear that behavioral health is on the same track now, that clinical health, if you will, has been on for a number of years, probably a decade, of data capture and sharing. So we're kind of at the point somewhere between stages 1 and 2, maybe inching up toward 3. But you can see the population health guidelines for meaningful use include population health management, care coordination, patient engagement, and clinical decision support, all things that we just talked about. Next slide, please. And next slide, please. So the major game changer, as we know, has been the adoption of the EHRs. This has been tantamount to all of the progressions that have been made in terms of digitizing data and being able to get a shared format for exchanging data. So the EHRs are finally now pretty much in place. Actually, will be at almost 90% adoption by the end of this year. This chart only goes up to 2013. And this has had a tremendous impact, obviously, on the ability for us to gather and share data. But it has its limitations, as Steve pointed out. It doesn't capture a lot of the data that sits outside of the EHR per se, such as clinicians' notes and so on, which we're going to talk about in a second. Next slide, please. So some of the downstream effects of the EHR as platform plays would include the EHR database and analytics platform. And you can see that they're feeding 3 different types of data sourcing and reporting: meaningful use compliance, population health, and clinical quality reporting. And the business indicators, the intelligence around key performance indicators that are outcomes of being able to manage data in an effective manner such as this. Highly structured, and there's a limitation there in some respects, but at least we're now able to see sort of like an X-ray. We can see into the data. We can see into the patient populations. Next slide, please. One of the things that has been developed that has been a real asset for folks that are starting to aggregate this data is the unstructured data, taking a look at stuff that is not in formatted boxes or check boxes or whatever, which is 80% of the healthcare data is unstructured. It's either notes or transcriptions or clinical observations, all sorts of information that is in these notes that is not available in the EHR unless we apply natural language processing. And we now have the annotators to extract most of the data into structured data by defining the rules of engagement in terms of data mining here, but also having the intelligence to look at disclaimers of information that exist, the so-called detection of negations. Next slide, please. And so that you can see the unstructured free text using analytics now becomes structured EHR data that can be used for our top 3 categories, like we saw, of meaningful use, compliance, enhanced clinical reporting, and accurate business intelligence. So this transition from being able to work strictly with structured data, now incorporating unstructured data, of which mental health includes a lot. So there's now an ability to start matching the unstructured with the structured to add even more value to the data analysis. Next slide, please. One of the things that is fundamental to this evolution of being able to unify data by integrating the mental health and behavioral health data with the clinical medical data is the use of a data model. Data models in this industry are the prerequisites. They're the foundation building blocks, if you will, for being able to structure hierarchically data into a system of data sets that allow for easy access to the data and, more importantly, the ability to look at causal relationships among the data sets. IBM just announced and has just released its new data model, 2015, that includes mental health, history, substance abuse, criminal justice, which is a big play in the mental health and substance abuse categories, socioeconomic history. There is also care management crisis plans for the first time that have now been integrated into the broader model, contingency plans and so on, and also updates to the existing plans so that we now have a seamless integration for coordinated care that is pervasive among the care plan team members and those who are delivering care at the point of care. Next slide, please. So this is a really important juncture in this journey because through the integration of unstructured and structured data for mental health, behavioral health with the clinical, the social, the genomic, we now have a comprehensive picture that shows the correlation and the causal relationships, the causal relationships among these data sets. And that's really the holy grail, is being able to look at relationships, hierarchical, interdependent relationships between diagnosis and outcomes, between different types of treatment and combined therapies. And that's now all possible. Up until a few years ago, we wouldn't even be having this conversation. Next slide, please. And one of the other aspects of the data model is the so-called CCD. You folks are surely familiar with that. It's part of the continuity of care document. It rides on an HL7 framework and an XML-based markup. So it's a way to share data electronically across many different data sources or recipients. Again, it's an extension of the data model because it adds content to the context of the care. Next slide, please. So a couple of the population health assessment tools that we have available right now, which are in use and are part of the IBM framework, includes the population assessment components. And I'll just look at one of these, which is the risk projected utilization. You can see patient per member per month based on condition and type on the left hand, and you can see some other attributes there. But more importantly, on the right-hand side in the circle, for the first time, you're seeing mental health show up as one of the 9 most costliest diseases, if you will, among that cluster. So this is just an indication that now these mental health patients with mental health disorders and behavioral health disorders are now showing up in these care management frameworks. Next slide, please. This is a depiction of an actual representation of being able to track and find the comorbids with identified mental health disorders. So you can see the first 5 are lined up as the selected conditions, and 6, 7, 8, 9 are the mental health disorders. And what this slide depicts is, again, the comorbidities crossing over among chronic conditions into behavior and mental health disorders. Questions remain, though, how many remain undiagnosed, and how will we know that they're undiagnosed? And the answer to that, of course, is to have a ubiquitous test that the primary care physicians can administer or incorporate into their patient populations, like the M3. Next slide, please. So I'm going to move quickly now because we're running out of time, but I wanted to leave some time for questions. So what I'd like to take a look at is just quickly how similarity and at-risk analytics work. So it's based on cohort, understanding cohorts and patient similarity, so that we can analyze what happened with the cohort historically and reasons why these events occurred, and then be able to predict the probability of a desired outcome for our specific patient. So we have 2 views. One is the rear view mirror view, which gives us all the data of where we've been, and then the windshield view, which gives us a prediction window to be able to help predict the outcome of this patient, and this is what creates the care plan. So the care plan is created out of historical evidence to be able to take a look forward snapshot of where this patient most likely will then end up in this trajectory based upon these drivers within care. So it's personalized through the care plan, and the care goals are basically predictions of what's the best outcome that we can hope for this patient given diabetes and depression. Historically, we know that if we do this, the patient will get worse. We know historically if we do that, the patient gets better. So it's fine-tuning that lens into the care of the patient based upon analytics, both retrospective and prospective. Next slide, please. I think we'll skip over this for the sake of time, but this is an in-depth view of how the patient risk stratification actually works. And it's very similar to what I just represented before, but in quite a bit more detail of what plans and care coordination solutions work best and how we can track patients like Steve and Mark suggest. The next slide, please. Same thing here. Historically, we know which care plans, whoops, I'm going to back up for a second. Thanks. Historically, we know which care plans worked and which didn't. And that's how we apply care plans to individual patients in a longitudinal fashion so that the care coordination is distributed among the patients that fit certain models and therefore have certain specific types of care plans. Next slide, please. So then we move into population management. Once we found them, how do we manage them? And probably the most important aspect of that is workflow. Workflow integration for care coordinators based upon these initial identifications is very difficult. And the reason being that you're now combining clinical care with mental health care, and you're also combining it into personalized care plans where you can have multiple comorbidities. You could have cancer, diabetes, high blood pressure, and anxiety. So it gets quite complicated, and that's why the population health management framework for population management is so important so that you can get streamlined care plans. Next slide, please. I'm going to skip over most of this. You can just do the build stop with the next one. But this shows you basically how the patient registries, which Steve referred to, populate the integration engine, the protocol engine, the communication, and the predictive modeling, which is all combined now into one analytics view, which fully automates patient engagement, the team-directed solutions, and the individual tools for engagement. Next slide, please. This is another depiction of a similar aspect of this, where outreach and mind transition are for all patients, and then you can get down into team-directed goals. This is where the care managers would come together around the patient-centered medical home construct to coordinate and provide insights into better care, and then finally the engage of the individual patient who wants to be engaged in certain ways or who doesn't want to be engaged in certain ways. And so it's customized to that specific patient. Next slide, please. This is just a statement about why care coordination is so costly if it isn't run properly, and also the notice that the most likely to be readmitted, number 2 is for behavioral health discharges, and number 5 is for alcohol and substance abuse. So you can see the impact on admissions and readmissions, much as Steve has already identified. But the costs are pretty significant. Next slide, please. And the last part of this framework is the measurement. And you can see how the measurement is displayed here. At the very bottom right, you'll see that all of this is pre-built. So if the data model is properly created and drafted and engineered, then a lot of this data here can be pre-built into standardized reporting, which is obviously one of the more important aspects of what you get out of the measurements. How are we doing? Are we complying? Is our inpatient quality and efficiency optimized, et cetera? Next slide, please. So this is one of my last slides, and then we'll turn it over to wrap up with some questions. But we're looking at the rewards for implementing this integrated care go beyond, I think, what we might first assume. We see and hear about mental health in the news every day, probably every hour of every day on CNN or whatever. about what the scope of the problem is, and no one really understands how big it is. They just understand that it's a massive problem. How do we get these people into treatment so that we don't have these extraordinary outbursts that cripple our society? So if we can open up the door to the PCP and allow them and their team to be able to identify early on and start treating family members with signs of mental illness, we have a huge opportunity here as a society to correct that problem, but also to better our society. Less money will be wasted. We can start treating a whole person. We can get rid of undiagnosed mental conditions that turn into huge problems down the line, both as comorbidities and by violent outbursts. Criminal justice system, if we could diagnose nonviolent prisoners and harmless mental disorders, get them into the community residence programs or community-based treatment programs, we'll save a fortune. And CMS will also save money through CMS by integrating the mental health care with the clinical diagnoses. And the providers are enabled and empowered to treat the entire patient if we can put these two data sets together. Obviously, better care for the patients. And then lastly, the employers in our economy. They're happier and healthier, as Steve indicated, with fewer employee missed days, sick leave, hospitalization, et cetera. Next slide, please. And this is a wrap-up slide designed to show how all this fits together. I borrowed this from Kaiser, who has probably one of the best inclusive mental health and behavioral health plus medical health constructs that I've seen. It's one that we've modeled a great deal of our work on. And you can see here the screening and stratification, which is what Steve talked about, and how it can be administered. The navigators, which are the care coaches, focused on risk stratified cohorts. Co-location is a critical point because care is now being delivered, as we all know, not necessarily behind the four walls of the hospital, but care is distributed across the entire community. And these need to be connected so that all caregivers at multiple sites are working off the same page. The health homes we know have been very successful, and we're now seeing more and more behavioral health strategies being introduced into the health homes through education and through the inclusion of psychiatric social workers or psychiatrists or other folks that are now brought to the PCMH table. And lastly, we talked quite a bit about the system-wide data process integration for care coordination, outcomes, analytics, and also to drive up quality and drive down cost in the reporting format. Next slide, please. And I'll leave you just with this, and then I'll cut out. But my four primary, I guess, bullets or takeaways are these. We all know now about the integration as an imperative, the implementation of provider-based data models that include mental health and behavioral health, incorporating simple mental health tests, which the M3 is. It's a short 27-questionnaire test that provides incredible insights, actionable insights into the relationships, particularly among mental health. But if we don't have a score and we don't have a screen and we don't have an assessment tool that's ubiquitous, that's used across our whole system of healthcare within a mental health construct, we won't be able to compare and contrast what other people are doing with their patients. So it's important to start to standardize on a couple of basic tests so that everyone's talking the same language. And then, of course, the last part is being able to take a look at the patient-centered medical home environment and being able to provide new care management technologies and advanced decision support tools, such as the Watson Advisor. Next slide, please. So these are again, a categorization of some of the rewards of implementing the new information technologies that we just looked at, and based upon what Steve had to tell us about the financial, the social, the legal, and the practice areas. So I think that's it for me. Next slide, please.
This is Steve. So let's skip this slide and go right to some questions.
Steve, thanks for the invitation, because there have been a couple that have come in, and I want to make sure that we get on the table. One is dealing with what the panelists' thoughts would be relative to provider payment model reforms that might be necessary to achieve the collaborative care, integrated care model that you're speaking about.
Well, let me speak to that real quick. So CMS has actually, in their annual physician fee schedule piece of legislation that comes out in the Federal Register, they added a series of requests for comments about that very thing. How should we pay for collaborative care? Because the psychiatrist is not providing any face-to-face fee-for-service type service. And so how is it going to get paid for? Is it going to get paid based on a per patient per month sort of deal like the chronic care management codes, or will it be something different? So the American Psychiatric Association has put in comments about our recommendations, and I think others have too. So it's very clear to me that, at least for CMS, they're starting to realize that there needs to be a payment mechanism to really pay for this, because the standard models just don't work. And I think commercial payers, some of them have started to do this on their own. Others will probably pick up the ball with CMS's effort, as they oftentimes do. So it will require some changes, and I think those changes will involve some sort of routine payment on a per patient per month sort of basis would be my guess, or on how often you review a patient's case, something like that.
Good, thank you. Another listener sort of echoed, I think, what I've been hearing today from the two of you relative to the potential success that can come out of the integrated model. The question I would have is, as probably the least qualified to know based on the data, are the PCPs up to it? Given that the data flow that M3 might provide them, or other screening and monitoring tools, what's the literature suggest, or your personal experiences suggest, as to the sort of the readiness of the PCPs for this model?
So I would say that there's certainly, and this is from my own experience as well, there are quite a few primary care practitioners who feel comfortable treating certain behavioral health conditions. Maybe that's alcoholism and mild to moderate depression, but not psychotic depression. Maybe bipolar disorder when it's mild on the low side, but if the symptoms really start to get high, then they're going to feel more uncomfortable and want to either need some backup or refer out and then back in possibly when they're more stable. So those are some of the things. Others just, I've run into quite a few primary care doctors like, I don't want to have anything to do with this. This is not my bailiwick. Those same primary care docs might feel the same way about certain other medical conditions and want to only refer out. So it has to do with the comfort level, and I think we need to do more to educate and train and offer resources to primary care practitioners so that they feel more comfortable managing certainly at least the milder and moderate conditions. While psychiatrists, there's a shortage of psychiatrists, and I think part of that is because, managed care has kind of kept the rates very low, and so a bunch of us have kind of come out of managed care. But if they start referring just the ones that really need a lot of help and not all those patients, I think we'll be able to do it, and having tools to help them do a better job will be part of it. The APA just got over $2.5 million contract to develop training for about 3,500 psychiatrists to be able to provide this collaborative care consultation to primary care providers. So, psychiatrists have to step it up too, and we're starting to do that.
Great. I think we'll continue on for maybe another 5 minutes so that we could address the questions as they come in. Listeners, if you have additional questions, feel free to send them in, text them in to us, and we'll stay on for just a couple of more minutes. This one probably goes to Charles. The listener says screenings are fine, but it seems like data analysis could make the system more targeted, particularly in identifying potential cohorts of undiagnosed behavioral health conditions. Would you be able to speak to that?
I'm not quite certain I totally understand what the question is.
It seems like it's looking for identification of conditions even beyond what the screening tools being described might suggest, but I may be misreading it.
I don't know, Steve, can you comment on how M3 can be used as a tool?
Well, yeah, I mean, I think what I hear in that question is, the difference between a screening, which is essentially what's the likelihood that somebody might have one of these problems, versus ongoing assessment, which is what are their symptoms, are they better, are they worse, and how to use that data, especially in a larger sort of data model, just in the same way that we have clinical decision support tools that help with making decisions about what antibiotic to choose. How do we develop these same sort of tools based on a person's symptoms that are somehow rated using, the M3 tool or other tools, and are pieces of data in a computer system, whether it's an EHR or something else, to provide better support, better help. That's kind of what I'm hearing from that. And Charles, you might have something more to say about that piece of it.
Yeah, that certainly fits into the decision support construct of the retrospective and the prospective, being able to do predictive modeling based upon, as you said, more of the longitudinal assessments to be able to track how this person's reacting to certain interventions, certain therapies, certain drugs, et cetera. That's definitely a very, very strong point in favor of decision support the way we've discussed it.
Great, thank you. Charles, while we have you on the spot, certainly the industry is pretty well aware of the power of Watson. I didn't hear you say much about Watson advisors for integration of mental health into clinical care. Is there a reason for that, or is that something that we might look for in the future?
That would probably take up a separate section, Mark, if you want to put that on the table for folks if they're interested. There is a tremendous amount of effort going into Watson, as everyone knows. IBM is basically betting the future of cognitive computing in part on the healthcare industry. The reason that I didn't get into it is because basically it's going to be an advisor role. It's going to be, as Steve and Mark and you were just talking about, truly a decision support companion. And we are now extending the data model, since we now just finished it, into Watson for integrated mental health and behavioral health care. So actually the first integration that I'm aware of that on any scale where you've got confidence levels that can be established by historical evidence, which is the hallmark of Watson, that is underway right now. And in fact, we have a couple of betas that we're getting ready to launch in that particular area. So stay tuned. I mean, it's a big deal.
Well, maybe it's something we could catch up with you on in a future session like this, as there's things to report back from those betas. We certainly please come back and give us an update. I just got a note in from another listener, which asked the $99 question about cost for usage of these tools and deployment of the tools. The listener points out that PCPs are already struggling for profitability. Are we asking too much from a cost perspective? And I suppose that answer, you can frame that answer both from an individual practice perspective and an organization of practices, whether it be through a IPA, an ACO, or whatever.
I'll do a quick one on mine, and then because mine's going to be a simpler answer. So, for example, for use of the M3 and the M3 clinician platform, we have a few different payment models, but essentially you're talking about less than 25 cents per patient per month, or under $3 per patient per year. And there's certainly a lot more costs by not doing that than there are for that. So we make it very nominal. On the clinical decision support, predictive analytics at the IBM's, Watson, I'm sure that's more than 25 cents per month, but maybe Charles could talk about that.
And also, Steve,
right. And have you, before I leave you off, let you off on that, have you seen payers, yes, it sort of dovetails back to the earlier question that was asked, payers yet recognize the, given the advantages.
Sure.
You were, Steve, you were quite persuasive as to the total cost of care being favorably impacted by this sort of dual diagnosis. Any payer stepping to the table with the models that make sure that even that 25 cents doesn't come out of the PCP's pocket?
Yeah. So, there are a number of CPT codes, and these are a little bit tricky because they're very payer-specific, and sometimes they're dependent on which diagnosis you use with it. So 99420, for example, health risk assessment will oftentimes in some payers be paid as long as you use, I think it's V7 9.0, which is essentially, I forget what it means actually at this moment. There's a few other codes like 96103, which is a psychological assessment administered by a computer. There's a 96127, which was a new code starting January 1st of this year, and that was specifically about either screening and or assessing somebody's behavioral health symptoms, including depression, anxiety, substance abuse, and then Medicare has these annual codes that they pay for depression screening and for alcoholism screening, G0444 and G0442, I think. And these are generally paid somewhere in the $15 to $35 range, something like that, per use. So there are codes that can be used to recapture some costs and then some.
Okay, then why don't we wrap up with Charles's view of managing the cost?
Sure, Mark. Many of the products and services that are currently available from many vendors, not just IBM, but have gone to a new model that we now call, per patient per month, and it's also based upon bundled payments and risk taking by the providers, more so by the providers now than the payers. We've seen a huge shift over to that kind of model rather than huge capital expenses to put hardware, software, and applications on the floor of the providers' facilities. That's pretty much all gone away, and that takes away a lot of cost. So what the value proposition is for IBM under cognitive computing is to be able to basically have access to those tools in a cloud environment so that you can load up your populations, you can do your cohort slicing and dicing, you can come up with the top 10 utilizers of your services and be able to hone that down. In other words, to take the cost out of the environment. And the trade-off is that, as Steve indicated, you invest $1 in integrated care and you can save upwards of 6. So in other words, there's an ROI built into this scheme, if you will, that already ensures the fact that for every dollar you invest, you're going to get a return on cost savings that will at least equal to, if not go beyond that dollar invested. So and then the investment, upfront investment, is much, much lower. The barrier to entry is dropped to a per patient per month basis. So you only pay for the services that you use. You don't have to do it on-premise. You don't have to have big computing power. You can just leverage the cloud and IBM's resources and assets. and create your own go for it kind of environment. So that's the short answer.
Great. Obviously, this is an area where there's lots of opportunity for cost and quality improvement over time, and so we will hopefully invite you back in a couple of sessions to hear about progress on all of these fronts. Whitney, would you let the listeners know about how they can access materials going forward, and thank you for all of your participation, for sticking with us overtime.
Thank you for joining us. This concludes today's webinar. And approximately 2 to 3 business days following the webinar, Epstein Becker Green will communicate the availability of the webinar recording and access to the PowerPoint materials. We hope you'll be able to join us for upcoming webinars. For additional details or recordings of previous sessions, please visit www.ebgadvisors.com. Thank you.